And so I want to go over the syllabus in detail so that we all know where we stand right now and where you need to stand by August 8th. That's the last day of classes. So let's get into our case study. All right. So here's your dispatch information. Let me do this. So you're dispatched for an elderly female who's weak and dizzy, complains of extreme fatigue and your syncope. Dispatch tells you she's a diabetic type 1 with a pump. Now, when you get there, she's sitting upright, anxious but cooperative, speaks in complete sentences, and no acute respiratory distress. So let's break this slide out into two parts. Let's go with dispatch. So, Colin, on the way to the call, based on the information that you have in here, what are you thinking as far as differential diagnosis, and what are you trying to get yourself ready for? Could be. Okay. Anything else? Now, remember, when you're thinking differential diagnosis means two or more. Okay. So she could be hypoglycemic. Nailed it. What would be another one? Help him out, Chris.
Any sort of cardiac issue at all. I heard chest pain. Is that true? Oh,
No, it's a cardiac. It'll be a cardiac. But now, again, when we're looking at this, there's nothing in the dispatch information to indicate chest pain. However, you are on the right track.
when I hear I'm with this, I'm trying to get a 12 regard.
Okay, listen. Wait, hold on a second. Listen to what he just said. Okay, everybody be quiet for just a second. Say that again because that is important.
So, if anyone ever checks the box of fatigue or weakness, especially in your syncope, I'm gonna get a 12 lead. Like that's automatic.
Okay, good. Now I would clarify that with it and say I'd back off a little bit on anybody with fatigue. Now we'll talk about this in a minute, but anybody that's near syncope should get a 12 lead, and I would go so far as to say I don't care how old or how young they are. Ashton.
I would say one thing I was going to add to that, like the portion of why you would want a 12 lead is because the syncope and possibly the dizziness is coming from a perfusion issue. And especially with her advanced age, like the vessels do like tend to start like losing tone.
Uh-huh.
So that could maybe be the reason why she had that simple episode. Or the fact that there's other underlying.
So remember in this situation, and Ashton, you're on the right track. Remember, which classes of patients present with atypical signs and symptoms, Tacey? And all right, so she's 3 for 3. Okay, she's 3 for 3. She's elderly, she's female, and she's a type 1 diabetic. Now we can see this in type 2 diabetes, but boy, it goes way, 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 way up if a patient is a type 1 diabetic. Okay. Now, this is important because, again, as we'll talk about when we go through the syllabus, right now, what I'm trying to do is to get you ready to take your registry exam and to take it one time. And that's all because you've passed it. I only want you paying registry one time. And this is critically important because, again, some of the questions that you're going to see are going to be dealing with that dispatch phase. And this is new from what they've done in the past. They've added this over the last 2 years. So again, when you're thinking, Caden, on the way to the hospital, begin thinking of these are my differential diagnosis. And as you get more information, that funnel will begin to narrow. And understand, you may never get to the point of where you have one conclusive diagnosis. Not even cardiac arrest is a diagnosis. It's actually a symptom. There's something that caused that cardiac arrest. And you and I as paramedics may never know what caused that cardiac arrest. So you get on the scene. She's upright. She's scared. Wants to be very cooperative. She's talking. No respiratory distress. So her airway is open and clear. She's breathing 20 times a minute. She's got a little bit of accessory muscle usage when she stands. Now, why would you have asked her to stand?
To assess if she has orthostatic hypotension.
Okay, so very good. So again, there is a debate on whether orthostatic hypotension exists. I believe it does. I believe it really, really does, especially in patients that are dehydrated. Remember, this lady is a type 1 diabetic, and we're really concerned about her blood sugar being either too low or too high. And we haven't gotten into the assessment completely yet, so we don't know if she needs glucose or if her glucose is so high that she's been vomiting and urinating so much that she's dehydrated. But that is important to look at. Breath sounds are clear, skin's cool. She's got just a little bit of JVD. Radial pulses are present, but they're weak and regular, no diaphoresis. She's awake and alert times 4. Her responses are just a little bit slow. Any concern with that particular finding?
Yeah, if responses are slow, that means there's something going on upstairs, which means there's some sort of deficiency, whether it's oxygen or glucose getting to the brain.
Okay. He's on the right track, but you got to add more to that. How old is this lady? She's elder. She's in her 80s. What would be some things that might cause her responses to be just a little bit delayed and be completely normal for her?
Dementia.
Say it again.
Dementia or Alzheimer's.
Could be potentially dementia. Somebody right here?
Just not kind of understanding what you're telling her.
Okay.
She might not hear you.
Yeah, understand. I've been real open with you guys. I wear hearing aids. If I take the hearing aids out, I'm not going to hear you very well. So I'm going to ask you to repeat yourself. And it's even more worse down in 153 when the students spread out. So if she's having problems hearing, we want to take care of that. Dylan, did you have your hand up? Okay. Chris, you had your hand up. Okay. So dementia, hearing, diabetes, if her blood sugar is low or high, that could indeed lead to the possibility of slow responses. As far as her vital signs, heart rate's 92, sinus rhythm, BP is 132/76, respiratory rate's 20, SpO2 is 96, on room air, N-tile is 33. Disregard that nasal cannula because we haven't going to put oxygen on her yet. That's my next question. And her temp's 36.8, which is going to be around 98.9, and her blood glucose is 212. Now, first of all, if this lady is a cardiac patient, does she need oxygen? Why not, Colin? You're right. Now tell me why you're right. Okay. Okay. Why else? That's one good thing. Say it again. No respiratory distress. James. Okay. Good, good, good.
We're able to see that she's perfusing well, like gas exchange weapons.
Now, let me ask. Go ahead, Chris.
I was going to say, can we maybe think about needing it later?
Can I what?
Can we think about maybe needing it later?
Yeah, you always want to. Here's the thing. Here's the thing that's going to make you a great paramedic. You're always thinking, what's the worst that can happen? Okay? Now, here's the bad news about being a great paramedic. In your real life, that can mess with you. And we'll talk more about mental health before you guys get out of here. So, again, you got to be able to turn that off of when you're looking at non-work related issues. Because if you're thinking about what's the worst that can happen in my personal life, you're not going to be very happy. Now, let me ask you a question here. Does it change your answers with this right here?
Depends.
Yes, I would say.
On what?
Is that normal?
Good. Good. What else? What else does it depend on, Ashton? Okay. What else does it depend on? Okay. Rarely, if ever, are you going to treat your patient off one diagnostic finding. Remember, I've told you time and time again, you're putting a puzzle together. If you take up that one piece of the puzzle and you look at it and you try to identify the picture from a single piece of puzzle, you're almost always going to be wrong. Okay? Same way when you're diagnosing your patient. You've got one finding here that might indicate that she would need some oxygen, but the rest of the evidence says no. No. Good job. Very, very good job. All right? What's this rhythm that you see?
Well, I think it's sinus tack maybe. Like right at 100.
No. No.
He was PR.
So now remember, sinus tack does not begin until 101. Okay. This is not sinus tack. This is not NSR. Let me enlarge it for you just a bit here and take a look. I think we got some sinus. We've got something in there with ST elevation. But now remember, can we call this patient a STEMI or an OMI?
No, especially not.
Not on one lead, no. But what is the rhythm strip?
Walkering.
Do I need to save y'all some spaces in 303 for the fall?
Yes.
Is it first block?
This is a accelerated junctional rhythm. Is that what you said? Look at this. Hold on. Let me show you. Is that what you said, Tacey? Okay.
Not out loud.
I didn't say
Not
that
out
chest.
Look at the P wave. It's bifurcated. First we go up, then we go down. And we see that consistently across in through here. Okay. Now, in the real world, if you call this normal sinus rhythm, and it's in reality a junctional rhythm, have you done a terrible thing? On what?
If it gets worse.
Okay. I would tell you in the grand scheme of things, calling it sinus rhythm, normal sinus rhythm, is probably not the worst thing that you could do because, again, junctional rhythms, especially at this rate, are probably not going to be a big problem. But again, if she has a junctional rhythm that's going on, what does that tell us?
That the top part's not working.
Yeah. So what else might we want to ask this elderly lady about as far as her previous history, and in particular her previous cardiac history?
I'd say, do you have any heart problems? And have you ever had a heart attack before?
Of course, we definitely want to do that. Okay. What else? Especially in regards to the electrical activity of her heart. Say it again. Probably not, because again, when you're putting your patches on, you're probably going to see that pacemaker, or you may see the scar. Now, remember, Ashton's giving you an important clue. Say that clue again, Ashton, that you just said. It's gone now, right?
It's like most of my thoughts.
Check. Well, we're going to get that in her history. So, yes, that is important. But for right now, Ashton said that means that the top part of her heart
Yes.
is pretty bad when the old guy has a better memory than you.
Look, you're like forever 27.
Yeah, whatever. If the top part of her heart, the atria, are not functioning correctly, what might we want to ask her about?
Any previous heart attacks?
No, not heart attacks. This is electricity.
Have you been diagnosed with any previous problems?
Such as. Say it again.
You got AFib?
Ask her about AFib. If the atria isn't working and the junction is now taking over, one of the things to assess on your patient is, have you had any history of AFib? The atria may have just gotten tired and said, hey, I'm taking today off. Okay. And so that's the key thing to remember. Okay. Ask about AFib. Now, doing your assessment here, she's got clear lungs. She's got a little bit of edema around the ankles, and she's got that little tiny bit of JVDs. Now, is this lady in heart failure? Based on everything I've shared, and I can go back if you need to look at the vital signs.
It's starting to fail.
Maybe.
Good answer. Why do you say maybe?
I would like to see some more findings, but especially with that JVD, and then if we have a cardiac history or not. I don't know if it's associated or not, but the decreased perfusion plus the JVD, and then I don't know if them standing up or not normally affects them or not. If it doesn't affect them normally, then I'd say definitely we could say
Okay.
perhaps.
Excellent. Very, very good. So, in the thing that we're looking at here, and the question is, what is causing this edema? It's a little bit of edema. It's not too terribly bad. And this little bit of JVD expression. And one of the things that we're looking at in here, ladies and gentlemen, is number one, how long has she had this? And we can correlate that once we ask her the question, well, how long have you been feeling the way that you felt today, Colin, for why she called you? And that's going to be an important thing that you're able to assess, okay? There are other things that can come about and cause JVDs and pedal edema. If, let's say that she's having early renal failure, that can cause a problem. If she is in early liver failure, that can cause a problem. So again, there's multiple things that can be going on with this lady in addition to the failure. So on your secondary assessment, she says that it happened really quickly and she wasn't doing very much. She says that the standing and walking gets the fatigue worse. It says no pleuritic component. What is that? How do we assess that?
Breathing. Ask her to breathe, and if it hurts while it breathes. Or...
Okay. What is pleurisy?
It's like inflammation of the pleural space.
Perfect. So remember, in the lungs slide against each other. The outer coating of the pleura slides against the inner coating, and sometimes that gets inflamed. The way that we assess this is we ask our patients to take a deep breath. And we can say it again. You can hear a cardiac friction rub, but not a pulmonary. Now, again, we didn't have time to get into ultrasound, but you can actually begin to see that on ultrasound. But again, if you've got a patient that's having chest pain that worsens when they inhale and gets better when they exhale, it's probably, key word there, probably not cardiac, okay? Under Q, she says it's heavy and she is just dreaming. Remember, this is sudden onset, okay? She's got a little bit of left shoulder tightness with no crushing pain. What is the danger in that finding right there for you? Little bit of shoulder tightness, but no chest pain. What's the danger there? There's two ways you can go on this, which could be very dangerous for your patient and for your career.
Disregarded.
Why? Disregarded as a result of what?
Yes, like they're like maybe she was doing something and like strained her shoulder. Like
The lady's in her 80s.
Yeah.
She's going to have stiff joints. So again, you have to remember that may be normal, but it also could be an early indicator that your patient is having a cardiac issue. And so that's why you want to take that in. And again, if you only base your diagnosis off of this left shoulder tightness, what would you probably do? You don't have anything else to base a diagnosis off of. Obviously, you're not going to have this in the real world. But if I told you got an 81-year-old female who's got shoulder tightness, what are you going to do? You're going to get a 12 lead, and even with a 12 lead, sometimes you can get an in-stem. Okay. Maybe tell her to do some stretches. Okay. Again, this is why you want to take all of these things together. She says it radiates into her neck and her left shoulder. The fatigue is pretty extensive. It's a 6 out of 10, and the shoulder tightness is much less. It's 3 out of 10. Started about 45 to 60 minutes ago, and she's had it since then. She got a little bit of nausea. As far as she's not been drinking a lot. That's what satiety means. It is that she drinks a little bit and then her thirst is gone. But she's seen that edema over the last few days, and she has no orthopnea or PND. What is PND? What's that stand for?
Positional nocturnal dyspnea or something like that.
Close.
No, it's not.
Paroxysmal nocturnal dyspnea, which basically means she has trouble sleeping at night, primarily because she's lying flat. She took her usual meds. She skipped the aspirin because her stomach's upset. All right, now let's take a look here, okay? If you're narrowing this down, remember you've got your diagnosis, and we don't have all the information yet. Here, I'm going to give you some more information. But based on where we're at right now in the assessment, are you ruling in or out hypoglycemia?
Ruling out.
Why?
Sugar's 212.
Okay, and why else?
She's not showing any other real factors. Like, because one big one that I feel like we would see would be like that, like polydipsia, where like that increased thirst.
For
but
low blood sugar?
not for high.
Okay, we're talking about low blood
Oh,
sugar
low.
right now.
Never mind.
So our blood sugar is elevated, but what else will pretty much rule that out in addition? What other finding do you already have?
She doesn't seem to be altered.
She's not really altered. She's responding slowly, but she's responding appropriately. Okay, so we can roll that out. Okay, what about high blood sugar? Keep it or toss it?
She would have the excessive thirst.
Okay. James, what were you saying? Well, she's got slight diaphoresis, I think it said earlier, but nothing really big in there. Maybe it wasn't in there. But again, so I would tell you we could probably, all of y'all's assessments are correct, so we can probably rule that out. What's that leave?
Heart.
Cardiac relationship.
And
Musculoskeletal.
thank you. So we've gone from out here to out here. We've gone from 4 potential diagnoses down to 2. That's very good. And it's in this situation that you got to remember Bill's number 1 rule, which is what?
Treat with your patient first.
Treat your patient on your own.
That's not mine.
Don't commit PID.
Treat what's going to kill your patient first. First. Don't forget that second first. What between muscular and cardiac? Goofy question. What's going to be the risk of at risk of killing her first? Very good. Okay. So as we go in there, we've seen her JVD. Heart is regular, no murmurs. Lungs are clear. Abdominal, she's got a little bit of right upper quadrant fullness, and it's non-tender. What does that right upper quadrant potentially indicate?
Wait.
So if you palpate, and this is one of the reasons why you need to begin palpating all of your patients so that you can see what a normal liver feels like. And when you palpate over here and it's go, wait a minute, she's 81, she's a tiny lady, that shouldn't be that big. What do you have to begin to think about?
Well, in fact, well,
As a result of what?
decided.
Right-sided heart failure. Very good. Excellent. I get excited when you guys are performing at this level. She's got some trace edema at her ankles. Why the right-sided fullness, but just a little bit of edema at her ankles? And this is speculation, but remember, you got to be thinking, what's the worst that can happen here?
I think maybe has breast out for you. Maybe we're in like an early stage.
Perfect. You're exactly right. Okay, so it's in early stage. Okay.
Because it's still able to make it up to that point, but that's where it's starting to back up a little.
Yes. Yes. Okay. So she's got cool hands. Cap refill is about 3 seconds. Does that delayed cap refill by itself, does that cause you any concerns?
No, she could be cold. She could be cold.
Or she could be dehydrated. You're right. She when that old could. All right, that's the third one. What's the other one? What's the other one? Female. Females cap refill have a tendency to run just a little bit longer. So where we learn that 2 second cap refill is normal, cold, dehydrated, elderly, and all females may indeed have a slightly longer cap refill. Again, don't take that little piece of information and build your diagnosis and treatment off of it, but that's going to be part of what you're going to be looking at. So we go from sitting to standing. Her heart rate goes from 96 to 104. BP goes from 130 over 74 to 120 over 70. Respiratory rate increases by two, or SpO2 gets a little bit better, 95%. End tidal has a mild drop. What are you thinking? Now remember, her breath sounds are clear. Oh, maybe. What are you basing that on? Okay, this is one of the reasons why I still believe that not orthopnea, but taking your blood pressures from sitting to standing are still very good and indicative. They're obviously very indicative for a patient that could be dehydrated. This lady could indeed be dehydrated. She's 81. It's very difficult for older people to get dehydrated. But what Colin said is spot on. Okay, so she could be in not only early right-sided heart failure, but also what? Left-sided heart failure. We haven't gotten to a 12 lead. Remember, we're going through this really, really slow. And again, the thing that we're looking at here is we're picking it apart. Okay. Speaking of a 12 lead, take a gander at that. First of all, let's identify this step by step. Normal 12 lead or abnormal 12 lead? Okay. Ashton, you went first. Why would you call it abnormal?
I think it's a lot. It might just be artifact.
There is a lot of artifact in there. You're exactly right. Okay. What else are we looking at here? Okay, so we've got some huge T waves in there. That might be concerning. And what else about her history can lead into not buffering, but adding to that concern, which if we got the peak T waves, that's a concern of what?
And she's having perhaps AFib issues, so that's it.
Very good. And what were you saying?
The pedal edema could be indicative of maybe.
Okay.
Build up.
So as we're looking at this, remember this lady is in prime diagnostic territory for having an MI. She's female. She's elderly. She's a diabetic. Okay. Understand, especially, okay, burn this into your brain. Understand that she called you just now, and how long has she felt this way? 45 minutes to an hour at the most. Now, again, this is why I say women are smarter than men, because if this were a man, he'd have waited 10, 12, 14, 16 hours to call. Okay. This lady called. Okay. Now, here's the thing to remember. When you're looking at this, would you activate the cath lab on this at 2 o'clock in the morning and it's snowing and raining out?
Probably not.
I wouldn't either. Now, I got a little bit of concern about, again, Holly mentioned in here about V2, V3, the peak T waves, a little concerning. There might be a little bit of elevation in there, but it's probably not enough for me to wake up the cardiologist. But you got to remember, when you get there in the early process, you may not see any elevation because it hasn't occurred yet. Okay. And again, especially a thing to remember is that if she's having a high lateral wall MI, those findings come up later than other parts of the heart. Why do you think that would be? Remember, here's our heart. Okay. High lateral is up here of the ventricle. Why do you think that if you're having which high lateral would be which leads?
V5 and V6.
Okay. So it'd be V5 and V6, or would it be 1 and 2? What do V5 and V6 look at?
The left.
Yeah. Your V5 and V6 are looking down here at your low lateral part. Remember, they're back over here. Okay. I'm back over here. All right. So if she's having a high lateral, the elevation may be delayed. Okay. All right. So let's get to the treatment portion of this. Sir.
Lead one in AVL, right?
Oh, I'm sorry. Lead one in AVL. Yes, you're right.
Oh, okay.
So All right, so now we've got enough information to begin to treat this patient. Let me ask you some questions. We've went through the progress. You've identified early on that she didn't need oxygen. Do you give her oxygen now or not? She didn't need oxygen. Nothing has changed. She's not having respiratory distress. Her SpO2 actually improved. She's got a little bit of retraction, but probably not enough to worry about. So I'm going to tell you, no, okay, at this point. What is going to be the next step that you're going to do, Chris?
We got 12 weeks of aspirin.
Good. Aspirin should be the first thing that you do, okay? You can get, if this patient were having respiratory distress, I would tell you to even still give her aspirin before you put on a cannula or a mask. Now, again, when you're practicing out there, in here we have to take things linearly and say first, second, third, and fourth. But again, you're going to have your EMT partner say, hook her up on some oxygen. I'm going to give her some aspirin. Matt? Okay, let's think about this for a minute. So we're at oxygen, ruled it out for now. We're giving her aspirin. Why would you give her nitroglycerin? Matt's right. Now, why is he right?
Well, since we've gotten our differential suspected cardiac chest pain and suspected ischemic origin, that's an indication for nitro. I would just take another blood pressure reading, and if it was like a 120 or above, and even 120, I might, be kind of iffy. But if we got a line, if not get a line, it should be good.
So there's her blood pressure right now. Okay. She's complaining of left shoulder tightness. Why would you give nitroglycerin for shoulder tightness? I've already told you that, Matt's right. James?
Because it's a smooth muscle relaxer, so it doesn't make that noise.
Excellent. Good. Dylan?
Say that blood's all backed up, so expand itself for it to move. Expand the whole.
Do you know that for sure?
Well, we do.
I'm suspecting.
I'm pretty confident.
Why? Why are you so
The
confident?
outpatient, the liver was backed up and the adrenal as well.
And the JV.
Okay. All right. Very good. Very good. Matt, you had your hand up. Okay. Yeah, so what I would tell you is giving this lady nitroglycerin at this point, she has a normal 12 lead. She's not having any respiratory distress. Her chief complaint is sudden onset of fatigue that worsens when she stands up, shoulder tightness. I would tell you she is the poster child for Bill's number one rule. Treat what's going to kill your patient first, because she is at high risk. And we don't know for sure because we don't have a cath lab in the back of her truck to go in and see if there's anything in there yet. But with this lady, if you give her nitro and you take her to the hospital and you find out later she's got bursitis in her shoulder, have you done anything bad? Not at all. Not at all. So, what do you need to do before you give nitro? You've already assessed the blood pressure, ice pressure 120/70 while she was standing. That's cool. So we'll have her sit back down. Hopefully the blood pressure will go up even more. What's the next thing you do before you give nitro?
Get a line.
You got to get a line, guys, especially in stable patients like this. This lady is fairly stable. Okay, you can still have an emergency and it be stable. So there's nothing progressing where she is getting worse rapidly. But again, if we give her nitro, and now all of a sudden we find out that indeed we have right-sided involvement, massive right-sided involvement because it hasn't progressed yet, or there's something else that's going on with her. Now what we've got is we've got a line to get started that we've already started while she's got great veins. Remember, elderly patients are going to have rough veins anyway. You can look at them. If they're a small person, you can often see them through translucent skin, and you're thinking, oh man, that's going to be an easy IV stick, and as soon as you touch it, it pops like a balloon. And so getting that line started first in this particular case and others like it is going to be really, really important. So we've given her no oxygen. We've given her aspirin. We've given her nitro. Now remember, what was her GI complaint? So,
Nausea.
do we want to give her anything for her nausea? So, here's something about here. What? Why are you going to go with Zofran? You're right. Now tell me why you're right. Okay. What else? Why do we not want this lady to vomit? Airway risk. If she goes unresponsive and she's vomiting, we got an airway risk. What else?
Vagal stimulation.
Vagal stimulation.
And or
Okay.
blood pressure.
Yeah. So again, these are the things that we're looking at here. We don't want her pressure to bottom out as a result of her vomiting. So give her some antiemetic, okay? And Zofran is going to be your best med to go with. Again, one of the things you need to tell your patient, because again, what's the main side effect with nitro? Headache. What's the main side effect with Zofran? Headache. Okay. So you need to tell her your head's probably going to hurt. Okay. Especially if she's never had the nitro. And then when you give her some Zofran, tell her your head may hurt with this as well. Okay. So we're going to position her in comfort. We're going to get her IV access. You're going to give her Zofran. We're going to recheck her glucose. And are you going to do serial 12 leads on this lady? I certainly hope you are. Any patient that you're transporting that you suspect has cardiac involvement should always get a new 12 lead every 5 minutes. Okay, that's a hard and fast rule. All right, if you've got a patient, especially one like this that is at a high risk for having a cardiac event, she's old, she is a diabetic, and she has complained of sudden onset of fatigue with a little bit of right shoulder or left shoulder tightness. This lady's going to get a 12 lead every 5 minutes. One of the cool things about that is if you're if you do that, you can actually watch and see if it does, watch it evolve. And if you've already done a 12 lead and you've got elevation in some leads and you go in and you take care of the pain and you give nitro and you reduce the patient's blood pressure and they begin to get some perfusion around that clot in the heart, you can actually start to watch that ST elevation begin to drop. So serial 12 leads every 5 minutes on the way into the hospital. All right, so we progress. Patient reports worsening fatigue and now mild shortness of breath on minimal exertion, just getting up and moving over to the stretcher. What are you going to do now?
Tell her to sit down.
Okay, she's sitting down, but it's still there. Her fatigue is worse. Her dyspnea improves a little bit when she sits down. But why is this happening? Is that a guess?
No.
Okay, it's the right answer. So this is probably tipping the scales more and more over towards this is a cardiac event and not a muscular event. Okay, her fatigue has gotten worse. And remember, that may be the only complaint these patients will have is fatigue. It's gotten worse, and now her respiratory distress is gotten worse as well. She now says that it's gone from tightness in her shoulder to a tight band from the left shoulder into the side of the neck. Concerning or not?
Yes.
100% is concerning, okay? She doesn't have any chest pressure, and your vitals while they're sitting in the ambulance, I don't know why I made this so small. Come on. Her vitals are 108, heart rate BP 118 over 70, respiratory rate is 22, SpO2 is 95, end-tidal is 29 to 30. So again, put all that together and tell me what's happening with your patient.
She's compensating for her part.
What do we want to be worried about for any patient that has compensatory shock who is geriatric? Can't compensate forever, okay? And not for very, very long, okay? There's your new 12 lead. Remember those serial 12 leads? Now, Lifesaver, tell me what you got going on.
Changes.
So, first of all, is this patient having a STEMI or an OMI? All right. Second question, which part or parts of the heart are involved? High lateral and
Yeah.
reciprocal changes where?
2 or 3.
Okay, so we got reciprocal changes in 3 and AVF. Why are reciprocal changes so important for us to look at?
They're
They can be a verification tool, but there's something even more important than that.
Most of the time, it's showing that those parts of the heart are starting to get ischemic as well, and so we can see it start to develop like that. Those parts are going to slowly start to die out.
Excellent. So remember, we've got high lateral involvement up in here. We've got dead tissue in here. Now it's looking down here at the low part, the inferior part, and that's saying that the inferior part is ischemic. We can do a little bit about reversing this up in here. You've already given her a really good plan of oxygen, aspirin, and nitro. Okay, but now she's getting worse. The clot is too big. And so she's definitely having that MI in the high lateral. Remember, I told you high lateral often is delayed in showing itself. Now, if she began having this chest pain 45 minutes to an hour prior to your arrival, under realistic circumstances, y'all are experienced EMS providers. How long do you think that you've been on the scene to the time that you're going in route with this patient?
Probably
10
like
minutes.
15 to 15 minutes.
Well, it's going to be longer than that. It's probably going to be about 20 minutes. I heard Ashton say 20 minutes. And it may be even just a little bit longer than that because it's going to take you time to get your assessment. Remember, she's responding slowly. And what we're looking at here is that we want to get that assessment done. We want to go in there and we want to understand that time is muscle. So this is what we're seeing. Remember, I said high lateral starts late, but now it has started with some reciprocal changes. So on this particular patient, if the patient is starting to become hypotensive, would you give this patient a fluid bolus? Remember where her MI is. This is where we get away from cookbook medicine. It's kind of like, oh, she's having an MI. Her blood pressure is dropping. Then, yeah, we would give her a fluid bolus. Would you in this situation or not? And why? Why?
Because we've already seen the struggle from. It's already like we already see like a decrease in the preload, and that's why we're seeing the buildup in fluid, and so just pushing more is just going to strain that.
That's one reason. We see. Say it again. What is she having? Keep going. So how do we fix it? Now again, the thing that we're looking at here is I think I heard Chris say maybe a small fluid bolus, but I would defer to what Holly just said because how do we know that a fluid bolus is not probably going to help this lady?
She's like already backed up. It's just not moving.
So we've got some fluid back up, but what else? What about that particular part of where her heart is?
It's preload dependent.
The right ventricle is preload dependent. We're looking at the left ventricle. Remember, we're looking up here at the high part of the ventricle. You got to remember the ventricles contract from down here up. So again, in essence, what we've got in here is if we give our patient a fluid bolus in here, it's not really going to help her. We probably need to give her a vasopressor if her pressure drops. Now, it hasn't dropped yet. Okay, based on the scenario, it has not dropped yet. But again, remember, you got to be thinking ahead. What am I going to do if my patient's pressure drops? Don't be sitting there and get so dialed in on, I got an inferior wall MI here. I got to watch this and see if anything happens, that you're not thinking of what's going to happen down the line. never learned to play chess, but they say the world masters of chess can think 6 to 8 moves ahead of what their opponent might do. That boggles my mind. But you can do that in here. You can be thinking, okay, I got a high lateral. That's probably going to, it is a pump problem. It's not a volume problem. Now, you can make the argument, okay, well, let me back up. What argument could you make for giving fluid as far as from a physiological perspective? Thank you. That's exactly what I was thinking. You could make that argument. That argument would not be the most accurate. I'm not going to say it's wrong. So in this situation, that's why maybe some push dose epi, if her pressure drops, would be most appropriate. Chris, you had your hand up.
Now, what is your reasoning for choice of pressors?
What's your reasoning for choice of pressors? That's a good question. What do y'all think? I mean, because you've got some choices of pressors. You could do an epi drip, you could do push dose epi, you could do dopamine, you could give norepi. So which one would you choose, Chris, and why?
I would do push dose epi because that's what protocol says. It's a little bit better than norepi in this case.
Okay, you're a smart man. I don't ever want to hear you say protocol says. Protocols can be wrong. Now, I'm going to tell you what you just said is right. What I would much rather hear you say is here's why from a physiological perspective. And this is going to carry you really, really well when we get ready to talk just a little bit about what your ALS contexts are going to be judged off of. If you just simply say, well, protocol says, it's kind of like you're a cookbook medic. I have failed if I turn you out as a cookbook medic. I want you to be a clinician, and you are. So again, why would push dose epi be the best choice in this situation? Now I want to hear from Chris because he knows. He's smart.
The type of the effects of the pressor. So I think epi's got everything, whereas other ones push dose is more focused on like peripheral, whereas I think epi has more of a focus on like central vaso stuff.
So if we give push dose epi, James, you had your hand up. Go ahead.
Wouldn't you want to use norepi as the first line for this?
Lose what?
Wouldn't you want to use norepi as the first line?
No.
Mm-mm. No. So we'll come to that in just a minute. So what's the value of giving push dose epi if we have to have a pressor in this particular situation? Now, I'm going to tell you, if we're looking at an inferior wall MI, a fluid bolus is going to be your route all day long. We're going to fill up, we're going to stretch that ventricle, and we're going to snap it back. But remember, we're way up here high in the top part of the ventricle, okay? And what we're needing is something that's a little more powerful, but without the risk of fluid overload. Now, push dose epi comes with its own risk. What are they? If we give our patient push dose epi, what are we going to cause?
Yeah.
What happens as a result?
Heart failure
Increase
because their heart
oxygen
can't.
consumption and
Say it again.
increase oxygen consumption.
Increases oxygen consumption. See, this is the answer I want. Okay, this is not, well, protocol says. This is, from a clinician's mind, it says it increases cardiac consumption. Do you feel like this lady's having an MI? 100%. We know for sure now. We've got additional information. And what we don't want to do is we don't want to increase cardiac workload unless we have to. Matt. Why?
Because epi is a beta 1, like it acts on the beta 1 receptors, and in this case, the heart is what's failing. Norepi acts more on alpha 1 receptors, which would vasoconstrict and help maintain.
Okay, let's think about it for just a minute. Now, how do you know that her blood pressure is falling and coming down as a result of peripheral vasodilation as opposed to pump failure? You guys have already answered this question about 20 minutes ago.
I mean,
I'll give you a hint. That right upper quadrant fullness, what did y'all say that might be from?
Blood packing.
Central blood.
As a result of what? Say it again. What's the most common cause of right-sided heart failure? Help her out, somebody. What's the most common cause of right-sided heart failure? We covered this in
Left-sided heart failure.
left-sided heart failure. What's the most common cause of left-sided heart failure? MI.
Oh,
So if this lady is having an MI, Matt, she's got tissue that's dying. So we're not dealing with a peripheral vascular problem. We're dealing more with a pump problem. And that's why if we give push dose epi, we're using that push dose epi. And I'll try to remember because I did a short podcast on this of using push dose epi as a bridge until we can get her into the hospital with something that can be controlled more minutely and accurate. So in this particular situation, it would indeed be your push dose epi that would be the most appropriate process that you're going to go for. Okay. Why do you think her end tidal is dropping? What's that an indication of? If your end tidal numbers begin to fall.
Increase resting.
Yeah. So what is that telling us about the function of the heart?
that is exchanging.
Say it again.
That's exchanging.
Well, now remember,
Well,
we started up higher, but now she's down around 31 to 30.
It's the opposite.
It's the opposite.
It's holding on to it.
Yeah.
So
So
that's why the numbers are-
So and the big thing we're looking at, this is going to be another piece of that puzzle. And this is why I encourage you guys, when you get out, study more and more and more about the use of capnography. This is going to be another important tool that's going to help you to understand this is more of a conduction problem than a fluid problem. It's more of a heart problem than a vascular problem as far as when we're going through that. So again, we've already talked about this of, let's say you got a student riding with you, brand new EMT, and they're saying, hey, we need to put her on high flow oxygen. Does she need high flow oxygen? No. And again, why would you, again, you're becoming teachers, why would you tell him? Probably you would wait till afterwards, but why would you tell him? What would be the reasoning that she probably does not need that high flow oxygen? We can cause more inflammation. And remember, what's the primary cause of cardiac disease? Is inflammation. So she already has some inflammation going on. We know because she's 81 years old. We know because she's a diabetic. Okay. And we don't want to make that worse. What's the other reason? It involves nitrogen. What happens with nitrogen washout? You get more vasoconstriction. So in essence, think of it this way, ladies and gentlemen. If you're giving a patient high flow oxygen and they don't need it, you're in essence what you're doing is you're giving the Narcan version of antidote to the nitroglycerin that you just gave. And if we give nitroglycerin to cause vasodilation, we give high flow oxygen when it's not needed, and we result in vasoconstriction because it negates the effect of the nitrogen in there. So that's why this is going to be really important. Couple things to remember, especially, and we're going to take a break here in just a second, but a couple things to remember in regards to oxygen and nitroglycerin for your patients. Number one, somebody remind me, what are the three criteria, one of which or more has to be in place to give your patient oxygen?
Respiratory distress.
That's one. That's two. And an SpO2 of less than 90%. It used to be 94, it would be less than, but now it's 90. If your patient is cyanotic, you're way late to the game. Yeah, most definitely we're going to give our patient oxygen in that regard. But again, they only have to have one of these, okay? The other, say it again. Yeah, you're exactly right, okay? And the other thing to remember is it is not an absolute contraindication to give your patient nitroglycerin if they're having a right ventricular MI. In that situation, if we get an inferior wall MI, what are we going to do to assess our patient for a potential right ventricular infarction? How do we assess our patient for that? Which one? Which lead are you going to move? I'm going to move one lead. We're going to move V4 from over here to over here. We're going to run another 12 lead. We're going to print it off. We're going to put V4R on it immediately before we do anything with it. If we see elevation in V4R, then that gives us an indication we've got right-sided MI. You have probably heard it before. So you all have been doing clinicals, and you'll hear it again. Oh, you can't give a patient nitroglycerin. That's a good way to, number one, kill patients, and it's a good way, number two, to miss a bunch of questions on your registry exam. We can give our patient nitroglycerin to a right-sided MI if our patient's vital signs present themselves as being high enough and stable. Okay. Now, under normal circumstances, you know that you can give as a paramedic, you can give a patient nitro if their pressure is 90 or higher. With a right-sided, I would like to see the pressure at 100 or higher, but always, always, always call in and do a consult with your ER physician. Okay. And the big thing to remember about this is right now, all y'all are certified and licensed as EMTs. In just a few weeks, if all goes to plan, you're going to be licensed as paramedics. But right now, you can help a patient as an EMT to take their own nitroglycerin. How do you know where that MI is? You don't. Because EMTs, theoretically, you guys can, but EMTs can't interpret 12 leads. So we blindly give nitro to all patients with chest pain until the paramedic shows up, and then we withhold it if we've got it on the right side. So again, you look at your whole patient. We're going to take a short break. Any questions on what I just